All right, so surviving GDV. This is something, when I was talking to Dr. Singh, we were trying to pick out our talks and yep. Okay, is that better? So yeah, we were trying to pick out our talks and I did ask him, I was like, how commonly are you seeing this? And it sounds like you are getting more and more of those deep-chested breed shepherds. So who's seeing GDVs in their clinics? Who's doing surgery in their clinics? Keep your hand up. Yeah, so a fair few people, and this is something in our hospital, generally, most of the time it's happening at night. Our emergency team are very good at taking these guys to surgery, and then we have the ICU team looking after the post-op care. But it's something that, general practitioners, if you don't have that option for a referral setting, it's in your hands. Hopefully Chris and I today can demystify a few things and just have you feel a bit more confident in some of your decision making. Before we get into that, I just wanted to touch on a little bit of the etiology, risk factors, and pathophysiology. It can be really multifactorial as to why these guys suddenly, for that reason, at that time, bloat and then twist. It's much more common in our large, deep-chested breeds. However, it can happen in any breed. I've seen it in a beagle. The older, leaner dogs, their ligaments get a bit stretched and their stomach's got a little bit more leeway. There is a genetic link, so some breed lines will find that GDV is more prone in that line. If they're really anxious, are they sucking in more air or got slower GI emptying? And a large single meal, dry or high-fat food, so dry food that fluffs up, so a big meal of dry food, a big drink of water is a perfect storm. When I just rechecked what the latest published papers were for this talk, I used to say that exercising after eating was another risk factor. So many of our owners actually say that's what's happened. When they've looked at it in the papers, they actually didn't find an association between exercise after eating. However, I still you wouldn't actively go and do it. Say to these owners, and we often say recommending going to smaller meals, scatter feeding, bowls that slow them down. All of those things are trying to prevent. So what's actually happening? What we think of it as is the the stomach kind of distends. It will rotate and it's usually clockwise. I'm going to leave a lot more of this to Chris of what's actually happening in surgery. It can go anti-clockwise, but the pylorus normally moves left and dorsal and the fundus moves right and ventral, and it kind of gives it anywhere degree. The twists can be varying as to how far around it all goes. You get compression of your major vessels, your major abdominal ones, so your portal vena cava, your portal vein, and your splenic veins. And when you think of that, you go, right, so venous outflow is blocked from those organs, and then you're going to get your blood is getting trapped in your spleen, your stomach, your liver, and your intestines because of that pressure, physically not letting that blood out. Oh, we just got a clicker problem here. Hang on. The arterial inflow continues, so you keep pouring blood into these organs when blood can't get out, and that causes a decrease in circulating volume for the actual systemically for the dog, so you get a decreased return of venous return because it's all staying in these organs, and decreasing cardiac output. Your diaphragm also gets, sorry, clicker's not happy today. Your diaphragm will also get compressed, and you can have, once they're really bloated, you can have problems with your diaphragmatic compression. I don't know, it keeps wanting to update. So the pathophysiology, and you kind of think of it on a spectrum, and I trying, in my head, I visualize like, what is that stomach looking like? From very healthy and viable and only got a partial twist, all the way through to a necrotic, dying stomach. The fallout of that is poor perfusion. You get anaerobic metabolism, the lactate's rising. These patients come often when we run that first blood gas on them, they can be very acidotic. The gut barrier fails, and it had poor perfusion. The bacteria can translocate. Sorry, it's for some reason decided it wants to update. Inflammation, vasodilation, and we get reperfusion and myocardial hypoxia once we've got them untwisted, which is a big player in why we get arrhythmias in them. And the gastric wall can become ischemic, necrotic, or fully perforate and rupture. Inflammation and endothelial damage is happening systemically, so these guys can end up with coagulopathies, multiple organ dysfunction. So the types of shock, and this is something when you actually look at this, you think, wow, these are why these patients can be in such trouble when they first present to us. They've got obstructive shock because there's not enough blood getting back to the heart. They've got hypovolemic shock because all the blood's staying in organs where it shouldn't be. They've got distributive shock sometimes if they've been it's been happening for a period of time and there's been endotoxin and cytokine release, so their pool of their vasculature is getting bigger as they vasodilate. And then they've got, some of them have cardiogenic shock as well because of all these secondary factors of the inflammation, cytokines, the reperfusion causes damage to that myocardial ischemia, and you'll actually get arrhythmias and reduced contractility. So it's a combined shock state, and really resuscitating these patients is key to having them survive. So again, your initial assessment, hopefully we're all going to remember this by now. The things I guess I'm thinking about, each time I'm doing this ABC in a certain disease state, there's kind of little things I'm thinking about more. In these GDVs, they've often been retching, they sometimes have a heap of saliva and muck in the back of their throat. I'm looking to see, do I need to suction this patient? Are they really, some of them are very critical when they come in, especially one that suddenly has happened in a morning and an owner's gone to work, they come home and find them, or if it's happened last thing in the evening, the owner's been asleep and wake up to find them for a prolonged period of time, they may need that airway intubated. You're going to assess their breathing because they're really an aspiration risk. All that gurging and retching, they can sometimes aspirate. They may already have arrhythmias, even pre-derotation, so I'm really assessing for that. They're often quite painful, agitated. What's their mentation and pain level like? It must be a horrible feeling. And then concurrent disease. This is something where, especially when it's in an older dog, what else is going on? Because if we, get our blinkers on, it's a GDV, must go to surgery, and they've actually got a splenic mass with hemangiosarcoma and mets through their liver. They've got underlying, they've been PU, PD, and losing weight chronically, and there's underlying metabolic conditions going on. Where is this owner wanting to go with this? Do we need to do some further diagnostics to see that it's appropriate to be taking this dog through a major surgery before continuing and making sure the owner's making an informed decision? So diagnostics, we will, a right lateral radiograph is your classic kind of view to get a diagnosis. If you're not sure, and you're seeing that double bubble, if you're not sure, get another view. Take a DV. We try and avoid flipping them on their back. The other key thing is have your history, where they're completely normal and then they're suddenly not normal, and it's a very acute onset that the owners generally can pick up on. In your physical exam, if you've got a tympanic cranial abdomen, they've often got signs of shock with their perfusion parameters, their pulses feel really weak, they're not themselves. Some of them might, when if the owners very first catch it, and sometimes they'll walk in and kind of seem, systemically not as compromised as more delayed presentations, but your right lateral radiograph can be it's generally very diagnostic. Taking another view, and while we're there in X-ray, we're going to get some thoracic chest X-rays because we want to, I've got aspiration on my list, But two, I want to make sure there's no sneaky lung masses or something that would indicate, have a much bigger conversation with these owners about whether we should be going to surgery. So you want to check for any underlying disease conditions. So if you don't have imaging, and I've talked to a lot of you now who sounds like some of you refer on to places that do, getting that done. But otherwise, this is something where it's not ideal, but clinical signs, signalment, and if they decompress with the stomach tube, you've probably got a GDV. It's something that's pretty classic. We talk to the owners early, and I tell them it's a surgical disease, so stabilizing this patient is only buying us time. So unless they're committed to go to surgery, us putting this dog through stabilization is maybe not the kindest thing. We talk to them about prompt surgery, and in a referral setting, we do have survivals of 80 to 90%. That does decrease, but if there's necrosis, perforation, or other systemic kind of the knock-on effect of DIC or multiple organ, your survival can drastically decrease. So we do just warn owners of this beforehand. If these owners can't go to surgery for a cost reason or a very different reasons, then, some quick analgesia while we've been having these discussions. We're getting analgesia into these guys very quickly, but humane euthanasia rather than trying to have them spend any time with them, or this is something that it's not going to fix itself. So we'll go through the steps of stabilization, and this is IV access. So we're generally getting in 2 IV catheters. They're normally quite large. Sorry, it's really frustrating that this wants to update now and won't click through. I might just ignore that. So 2 IV catheters. We've got one for rapid fluid resuscitation and one for kind of giving our medications, induction drugs, CRIs through for anesthesia. You can consider a central venous line if if they're really critical. Sometimes initially our emergency team will just have IVs in. If they're not looking great in recovery, I may put a central line in recovery, but we went through a phase where every GDV had a central venous catheter, but sometimes the time, the cost, and then these guys were bouncing back the next day, and some of them were getting out of hospital the following 1 or 2 days, so we felt it was a little bit overkill. We don't measure CVP anymore. So collecting our PCV, TP, our lactate, and our electrolytes, a baseline of our coagulation status, and then deciding whether the owner wants us to do a bit more diagnostics on any underlying health concerns. Are we going to be running full CBC and biochemistry? But that's not going to really change our initial management generally. So it's kind of those lactate for trends and our electrolytes that we're looking at. We're doing all of this simultaneously. So we kind of got the catheters in. The blood normally comes out of the catheter as we're kind of getting it taped in for doing our diagnostics, and someone's getting them started to be run while we're starting fluid resuscitation. You want to restore that effective circulating volume, and this is the time. These are generally large breed dogs, so sometimes anywhere between 30 and 50 kilos, and it's the one time I will say, I know last night I was saying, go slow with your crystalloids, be careful. Generally, these guys, they need appropriate fluid resuscitation to get them into surgery well. So we're giving a litre sometimes straight up, and often it's under a pressure infuser bag. We are getting it in quickly, and it's that balance between the damage to glycocalyx, say, and actually just getting volume into these patients. But I still am rechecking. You're giving about a 20 ml per kilo crystalloid bolus up initially, and then these large breed dogs, sometimes we may give another half a litre, or they may actually need another whole litre to have them stable enough to get into surgery. We're doing this while we're also, and the other consideration is if you're getting a poor response to your initial fluid resuscitation, do we need hypertonic saline to help us even get a more rapid expansion of that intravascular volume? Knowing that we've got to follow that hypertonic saline with some crystalloids, so with Hartmann's, or if all you have is saline, that's okay as well. And then some of them may still be critical, and we may actually be starting blood pressure support of dopamine or noradrenaline as we're going into surgery. You do want to avoid fluid overload, and these are sometimes the ones where they've needed to give a large amount of fluids in that acute setting, and then post the next day I'm starting to see huge urine outputs, maybe a bit of sub-Q edema, and I may actually then de-resuscitate them a little bit. They've got oxygen generally throughout just to help increase their FiO2 and any increase in delivery of oxygen to the tissues. We're giving pain relief, and again, in our hands, it's normally a pure mu opioid, so methadone, and then they're going on to fentanyl CRIs or morphine CRIs as you're going into surgery. If they're in shock, they're going to not absorb very well from their IM or their sub-Q. Antibiotics, we're only starting them pre-surgery if we suspect aspiration pneumonia, and that generally we've confirmed that on our x-rays. Otherwise, Chris will step you through. They do the intrasurgical cefazolin, and then depending on what contamination they have post or how the surgery's gone, we make a decision whether we're continuing antibiotics if they don't already have aspiration pneumonia. If there isn't any arrhythmias, generally you've got to really listen when you're examining them. Have you got pulse deficits? Can I hear an irregular heartbeat? If we've got ECG, we're putting it on, and we're starting lignocaine pre-surgery. And I'll go through this more in our ECG talk, but ventricular tachycardia, if there's sustained rates greater than 160 or 180, there's VPCs originating from different origins, so they look slightly differently, but they're still wide and bizarre. We're getting the R-on-T phenomenon, where we're kind of repolarizing and depolarizing at the same time, or very short bursts of VTAC. These are all things that would have me go on to lignocaine sooner rather than later. To stabilize, again, so you kind of very quickly IV in, pulled your bloods, they're running, you started some fluids, and you've given some pain relief, and the pain relief generally, it depends on these dogs. Sometimes they need a little bit more sedation as well. We might give them some diazepam or midazolam, as well as the opioid, to have them tolerate this, but we'll decompress them. This is how, again, we do it, which you can use generally a roll of bandage dressing that's got the hard hole in the middle. So if it's a bandage that's all the way collapsed down, that's not going to work because we want our tube to go down the middle. The dog does need to be appropriately sedated and analgesed, otherwise you don't want to get bitten doing this. Then the next step is getting your tube, which should work. Sorry, this video was about 3 or 4 minutes long as they were fiddling around a bit. You're going to have your stomach tube, you're going to measure it to the end of the 13th rib. So I just quickly hold it up. We have our standard kind of one where most large breeds are a similar size. We have a bit of tape on our GDV tube. And you want to lubricate the end of it, and you're gently going through. But if there is a little bit of resistance as you do pop through, but you don't want to be putting a huge amount of pressure. We have had, you could perforate things, especially if the viability down there is poor. So gentle and firm pressure, but don't force it. If it's not, some of them we're unable to decompress them this way. A lot of them we are. If you're unable to decompress them orally, then that's the ideal, because then you haven't stuck a needle into something that you're not quite sure of. The next step, you can trocherization them. And this is all kind of helping them in that acute setting for us to get them to stable to go to surgery. So we're going to prep a 10 centimetre area. You kind of find the highest and the most tympanic area, and it's a 14 or 16 gauge, and you hear a hiss once you go through. I think there is some audio on some of these videos, but that's okay. She's going in. And again, she'd palpated to the the highest tympanic area. And once you're in, you'll hear a hiss, and we'll just stay still and let as much of that air come out as you can. This is one of the @Dove videos. So this is the one, the training platform I'd recommend to you guys. And I've got no association with @Dove, but it just shows a lot of really practical videos. Then you're stabilizing before and reassessing before anesthesia. And sometimes this is all well and good, but sometimes your trends aren't improving and you've just got to get them into surgery. But generally you want to see that your heart rate's coming down, your perfusion parameters are better, If you've had a marked, quite a marked arrhythmia already, that the arrhythmia looks a bit better on lignocaine, and that your lactate has been hopefully decreasing with your efforts. However, if it hasn't, you still do need, it's a surgical disease. Be aware of any other underlying conditions and head to GA. But this is all general. Once we know that there's a GDV, we're pretty promptly having whole teams, the evening, the coordination that's getting prioritised. We've got, and the vet, the surgeon who's going to be taking, and that's just what they focus on. These don't get put in cages and left to wait. If you're in a lower resource setting, you're looking at your perfusion parameters and what's on in front of you. Does the dog clinically look a bit more stable? Yep, let's go to surgery then. So you've got to recognise, resuscitate, keep reassessing things. You want to just get them as stable as you can, and then we hand over to Chris and we send them off to surgery. I can click for you because
All right, so Ellie's done all the hard work for us. Now we're heading into surgery. And whenever we're operating, it's really important to have clear intention. What are we going in to try and do, particularly with emergency surgery? It wants to be efficient. You don't want to spend a lot of time thinking what next. So when I think about my goals of surgery with a GDV, there are clearly 4 things I want to do. So the whole reason why this animal is so unwell is we've got a malpositioned stomach. So we want to put it in the right position. We then want to make sure that we determine how healthy that tissue is, both the stomach and the spleen. Then I want to check to make sure there's no underlying disease. And then finally, I want to make sure we take steps to prevent recurrence. So that's the 4 goals that we want with surgery. So the manoeuvre that you need to perform when performing a GDV depends on the direction of rotation. And most of them are clockwise rotations around that long axis of the esophagus. We're going to talk about what you would look for. So when we have a clockwise rotation, the stomach essentially rotates into the greater omentum. So we talked about this previously, how it's a double sheet. The only entry point is the epiploic foramen, but when the stomach rotates, it actually goes into the omental bursa. What that means is you have a single layer of omentum over the stomach. Nothing else causes that. If the omentum has flipped forward and covers the stomach, it will be a double layer. So a single layer of omentum is what I look for to confirm that this is a clockwise rotation, because that determines the direction of derotation. So Ellie showed you this slide. The way I like to think of it is that proximal duodenal flexure is a bit like an arrow. And so that means that the right side, the pyloric antrum and pylorus, tends to go towards the midline and then wraps around the other side. So it comes ventrally and then ends up dorsal. Go to the next slide. And so when I'm standing here, this is how I am in surgery. The animal's head is this way, the tail is this way. I'm standing on the animal's right-hand side. When I identify that this is a clockwise rotation, with my right hand I reach in on the left side of the bollyward and I run my hand around. I hopefully will be able to feel the pylorus there. I cup that and I want to pull that around towards me. At the same time with my left hand, I push down on that body and I rotate it around this way. So I've got a few videos here that might help you show that. So we'll go to the next one. Well, this is just my fancy spinning. So the single leaf, once you derotate it, you can see the stomach dorsally. All right. So this is what it looks like here. Single layer of omentum. That's confirmatory. Okay, next slide. So let's have a look here. So we're going to reach down with our right hand, down the left body wall. Our other hand pushes it, and we derotate it.
Now the stomach.
So it's not a long process. If you know the procedure, it takes seconds. The first time I did this, it took a lot longer. I had the book open, and I was trying to figure out which way it goes. It took me maybe an hour to try and derotate my first one. But it's a very simple maneuver. Go to the next slide, because I've got, I think, another video just to show you from a slightly different angle. So we're standing on the dog's right-hand side. Head is up this way. tail goes down this way. So let's go to the next slide. We should have a video here.
So this is
And
a
single leaf.
270-degree clockwise rotation. So now what I've got to do now is to reach down this body wall here to grab
the pylorus,
pushing down with my
push down,
twisting
and bring it up.
Okay,
And
now
once we've done that, now we see the stomach in its correct position.
there.
It's not within the mental bursa. Okay, so is everyone happy with that? That's our maneuver. Yeah, it's controlled, it's smooth. We don't grab anything, we're just cupping it with our hands and moving it back around. All right, so that's the first goal achieved. We've repositioned our stomach now. The second part is to determine the viability. Now, determining viability of tissue, I didn't go into too much detail when we talked about the gastrointestinal tract, but this is a key skill because tissue, just like right back from our wound healing, it seems like ages, but just 2 days ago, we talked about, dead tissue needs to be removed, and it's the same with the gastrointestinal tract. So how do you determine if that tissue is alive or dead? Unfortunately, there's not a simple single test that tells you whether that tissue will survive or not. You look at the colour, you look at mobility, so peristalsis. You look particularly at wall thickness, because what I tend to find is the thinner the wall, the more likely that is that that's going to dehiss. If it's discoloured and congested, but still of appropriate thickness, and you can just check the thickness in another area of the stomach. If it's appropriate thickness, then I leave that in. So let's have a look here. We can see colour is one thing that can often change. And you can see the difference here. If we have this degree of discoloration, it's likely to be very thin. This requires resection. Now, I generally just ring bark that area with stay sutures and then cut it out. You can invaginate. The risk with invaginating is you're waiting for the dog to digest its own stomach. So I feel much more comfortable putting sutures, like a tie-over dressing, all the way around. I can lift them up and then I trim around it, and it's like a basket. So now I don't have the risk of spillage. And then it takes time, but you're going to bring that together as we discussed. But we're always somewhat concerned that we may have tissue left in that's non-viable, but unfortunately there's not a single test that you can use. You need to use all your senses as a surgeon, and this is a very hard thing to teach. But I think if it is appropriate thickness, even if discoloured, if it's just congested, it's likely to survive. Okay. Now the spleen in days gone by was commonly removed because it looked like we saw here when people went, this is necrotic. What I generally do is I look at the spleen, and you can see it here. Then I go on to the next step and actually perform my exploratory laparotomy looking for other pathologies, because when I come back, and I think I've got another slide here, you can see what looked to be very necrotic is just congested. And so if you look for pulses, and if you see good pulses, then it's likely that you've got a congested spleen and not a necrotic spleen. And so in many cases, I will leave that spleen in if it's only congested. I probably remove less and less spleens as I get older and older, because we recognise that if you take time, once you've repositioned the stomach, venous return will return normally to the heart, and now our patient's going to be more stable. So you've got a bit of time here. So I do an exploratory laparotomy and I come back and check. I take photos every surgery, because even over the course of 10 minutes, your memory can not always recall exactly what it looked like. And I'm always surprised after 10 minutes the change that you see. But just get someone to take a photo at the beginning. Then after you've done your X-lap, you can compare and go, actually, that looks a whole lot better. Your adrenaline is often going at this point. So again, using technology to help you. Okay, so again, this is just showing where you feel for pulses. And if I see pulses, I'm pretty happy to leave that spleen in, even if it's congested. So we've done our first two tasks. In fact, we've probably now done our third and completed our exploratory laparotomy. And now we want to make sure this doesn't happen again. So we're going to perform incisional gastropexy. So the gastropexy should always be performed after repositioning. It's hard. So we want to do the right thing, not the easiest thing. You can feel like a hero for a few days if you put it back in place, but that dog is going to retors. And here we are looking at some of the statistics. The recurrence rates have been shown to be as high as 80%. It's almost a sure thing this dog will retors again if we don't do something to stabilize it. So there are a couple of different techniques. I'm going to show you a range of techniques, and then I'm going to show you the preferred technique. The preferred technique is always the simplest technique that achieves the job. So I've only done this once. This is a tube gastropexy. So this is where we make a hole in the abdominal wall and pass through one of these mushroom-tipped catheters. We can then perform a gastrotomy. Go to the next slide here. You need to put a stay suture in around there and a purse string suture to seal that, and then you pull that stomach to the body wall. It's in the area of the pyloric antrum. The advantages of this technique are that you can empty a very distended stomach. The disadvantages is leakage. You've opened into a viscus. This is a hostile environment with the abdomen, and the risk of leakage is reasonably high. The other disadvantage is that when you pull out that tube, you need to keep it in for at least a week because you need a solid stoma to form. When you pull it out, you've got a direct connection between the inside of the stomach and the outside world. Now, when I was a resident, we did one case like this, but it was to see the owner's look on their face when this dog drank water and then leaked out the side, and I had to explain why we'd done this. It was a bit much. And so nowadays I generally wouldn't perform this procedure, mainly because it takes longer and it has higher risks. But you may read about it, and again, it's an acceptable technique, but it's not my preferred technique. I think it carries greater risk. Equally, there were two very well-described techniques. This circumcostal, where you take a tongue of the seromuscular layer and put it behind a rib, and then a very similar one, which is called the belt loop. And this was where you took a tongue of tissue from the pyloric antrum and you went through a slit in the wall. Pretty much universally, no one does these techniques anymore. And the reason for that is, although biomechanically these were shown to be the strongest techniques, it's the same thing with bandages. It's not about finding necessarily the best based on one measure. It's about finding a technique that achieves the purpose. And if our purpose is to prevent recurrence, if we put the cadavers or cadaver tissue in a biomechanical testing machine, the strongest, best performing technique may not be the best clinical technique. So what we understand now is the additional time it takes to perform these techniques is of no benefit. We want these animals back in the Ellie's ICU as soon as possible. So although they're very strong, they're not recommended. What I recommend is an incisional gastropexy. This is a very, very simple procedure to perform. It's important that you get the location correct. So you need to be in the pyloric antrum. So this is the angular incisor. It marks the differentiation between the body and the pyloric antrum. It's the pyloric antrum to the right body wall, just behind the last rib, about a third of the way to the ventral margin. So that's where we're going to make our incision. So we make that incision. I then bring it up to the abdominal wall and I stamp the abdominal wall. And you see a little blood mark there. I then cut vertically right through the transversus abdominis muscle, full thickness. That's where I'm going to suture the two together. So I take two different suture lines here. So here you can see the body wall incision. Go to the next slide. And what you can see here is I take two different suture packets. I tie the deep on both sides. And then I do one continuous suture up one side, then one continuous suture up the other. I use OPDS in most of these big dogs. And this gives us a very firm, stable fixation. Where I'm cutting in the stomach is not full thickness. We mentioned how the stomach has two distinct layers. So again, when you become comfortable doing gastrotomies and you're used to those different layers, you're going to use that skill set here. Because Ellie might get us to back up a couple of slides here, and we'll look at this incision here into the stomach. We're going partial thickness. We want to cut through the seromuscular layer. We want to see this mucosa, submucosa layer bulge. Now, it's hard because when you make this incision, you're scared of going into the lumen. So my top trick for you is to make the incision, then turn your blade upside down, and you cut with the top of the scalpel blade. It doesn't really cut, but it just separates those tissues. You won't go into the lumen that way. It just helps break those last muscle fibers until you see that mucosa bulging. So when you see that bulging, then you've got a nice edge, and that's what you suture. So that gives us a very strong adhesion. So we'll go back to the next slides here. So now we've performed our finished pexy. And then we close the abdomen as per normal. I don't lavage the abdomen, and I take it back to the ICU and hand it over to Ellie.
Alrighty, thanks, Chris. So this is often when the surgeon comes in, they're all happy, we ask them how it went, and they're like, oh yeah, it's fine, we've fixed him, you know, he's right. Don't know what you need this post-op care for, and we've spent all the money. No, not quite. No, they're very, this is a continuum of a team effort getting these patients through. The post-op reality check is that it isn't all over this patient. You know, the big thing that was, it was crucial, but we've still got all these negative effects of the fallout of GDV. So we've got our pre-op systemic effects are all still there of inflammation, acidosis. We're hopefully now going to really be able to trend in the right direction, but these patients are still critical. We'll just step through some of these. There's reperfusion now that we're dealing with. That glycocalyx may have taken a hit, and we're getting peripheral edema and leaky vasculature. Have we got arrhythmias? If there's any stomach or spleen tissue that was questionable and we have delayed necrosis happening, these patients, sometimes we just can't stabilize them, or sometimes initially they stabilize and then they acutely deteriorate again. So don't just think and don't trust every word the surgeon says, because sometimes they do their absolute best in there and there is tissue that it wasn't obvious that it's going to continue to necrose or have poor blood supply. But that's the biggest reason why we have these patients deteriorate post, is the underlying cause isn't fully fixed. So that physiology still needs critical care and close monitoring. That early recovery period, they're kind of coming into ICU, they're generally, you know, some of them have very slow recoveries and they take a while to extubate. We're getting what monitoring you have, and if that means it's just you know that you're continually reassessing that patient and doing that quick physical exam to look at your perfusion parameters. We want to see our heart rate coming down. We want to see their ECG, hopefully normal sinus, or if it is inventricular arrhythmias, that they're not at a rate that are systemic, that are cardiovascularly affecting them. We want them warm, quiet, comfortable, and just recovering from a big anesthetic. Pure mu opioids, so generally, in our hands, we have got them on methadone, fentanyl, or morphine. Initially, we are generally transferring to a fentanyl patches, using fentanyl patches over here. Yep. So once they're normothermic and been warmed up, we'll be placing one, knowing that we're going to be weaning our analgesia hopefully by the next day. We avoid non-steroidals like the plague, because we want that gut perfusion to have every chance it can, and non-steroidals affecting that can have huge consequences. Continue on oxygen, even if they're hypoxemic. And we continue gentle. I guess I'm just trying to say here, we're not still going with aggressive fluid resuscitation as long as we've fluid resuscitated them appropriately initially. So they're coming down to maintenance rates. So large breed dogs sometimes may actually come right down to 2 mils per kilo per hour. Sometimes they still do need some more, but this is all off your physical exams. Everything should be resolving, and you're watching for any changes in your arrhythmias. Arrhythmia management, and this is something, it is very common to see arrhythmias in these guys post. In that first 12, 36 hours, I'll step through. We're treating if it's malignant. If we've got a slow, a slow VTAC, which I'll go through in the next talk, which is called accelerated idioventricular, where we're getting ventricular complexes, but the rate's nice and stable, say, 120, they're cardiovascularly stable, we're not going to treat that. We're treating if it's fast, if it's really originating from different areas, or we've got that R on T where we're worried that that could lead into an arrest rhythm. Lignocaine, we're giving small boluses initially. We give 1 to 2 milligrams per kilogram over 30 seconds. We repeat every 5 minutes until we see an improvement of rhythm, and we don't generally do that initial bolusing of more than 8 mg per kg because I've made a few dogs seizure once you get up to that high rate. Then they're going on a CRI in the background. Depends how worried I am. I often, we're starting generally at 60 to 80 mics per kilo per minute and then decreasing down. We're correcting any underlying contributors to arrhythmias, so making sure they're comfortable. We look at a blood gas, and we keep, if we need to give more fluids or oxygen, we are. Some of these post-op dogs need a short period of an of a beta blocker to actually be able to get them off the lignocaine to get them home. The ideal with any of these underlying arrhythmia dogs where they've got arrhythmias from their systemic disease, we're lucky we have a cardiologist. We get them echoed to make sure there's no underlying cardiac disease, DCM in some of the larger breeds, or anything that would be contraindicated to giving this patient a beta blocker before we do it. If you don't have that, sometimes just looking at the contractility, how well is that heart contracting? It's quite crude if you're not but kind of getting used to looking. This is a patient that was getting right on the edge of treatment. And so sometimes there is a grey area. A lot of the textbooks will say greater than 180. Once they're in that 160 to 80, I'm kind of watching them like a hawk. If they're not that cardiovascularly stable, I'm actually going to jump in and treat a bit sooner once they're over 160. GI support, I can't emphasize this enough. If they're not really starting eating within 12 or 24 hours, we're generally slipping a little nasogastric tube because helping that GI heal and recover is feeding these dogs. It really does help motility and everything. So we will place nasogastric tubes if they don't get up and eating. Some of them are eating that night, the following day. We then stepwise add in our GI meds, our proton pump inhibitors, so omeprazole or esomeprazole, if indicated. We don't blanket treat all of these, as often if the surgeon's done done their bit, they've had, the perfusion improve, any area that was necrotic is out. Do they truly need gastro protectants? I don't over-treat. I think we used to put them all on these, whereas we only treat if we're worried. If we're getting coffee ground, they're vomiting up coffee ground fluid, or when we've got our NG nasogastric tube in and we check our residuals and it looks coffee ground, I'm going to treat with a proton pump inhibitor. If they look nauseous, we're going to give them an antiemetic. I saw one of the reps promoting your trade brand of meropenem, which is one of our preferred ones, plus or minus metoclopramide. I often find metoclopramide, I think we use it to make ourselves feel a bit better. I don't know whether clinically how much effect it has, but 2 milligrams per kilogram per day divided in, like we run that over a CRI, or you can do intermittent bolusing. You monitor them for ileus or regurgitation, and to be honest, the best thing for if their GI tract's not happy and not moving post-op, get them up and get them walking. It got far more effective than any of your motility meds. And some of our poor guys do get 2-hourly walks during the day, and then we let them rest at night. They go over to their standard 4-hourly checks. And keeping them calm. TLC, a happy dog, a calm dog. Sometimes owners come in and are sitting with them rather than a stressed dog recovering. Keeping these dogs comfortable and calm really helps them. So this is when it's starting to go wrong. So if they don't read the textbook and they're not just continually improving, I think there's always a reason. Don't ignore it in these guys. Something's happening that shouldn't be. They should just really every 12-hour period they should have been improving. So if they're not, I start either with the chest or the abdomen, depends what my physical exam is telling me. But you think those are the two areas where things can still be going wrong. So in the thorax, has it aspirated? And maybe our initial chest rads that we took before we went to surgery, sometimes that aspiration, when they first take in some stomach contents, we barely pick it up on x-ray, or it's really subtle. And sometimes we can, we think it's an atelectic right lung lobe when actually it's a big hyperfluid waiting to form a pneumonia in there. Have they got a pneumothorax? So has the surgeon extended a little bit too far? And it is quite common. They do have to go, make quite a large excision. Is have we got a pneumothorax on recovery that maybe we weren't aware of? Or sometimes the surgeons know that they've done it and they don't tell you that they've done it. And so we have had some that we've had to go and address that. So look in their thorax first, if they've got more a respiratory component versus often we're looking in their stomach, so in their abdomen. So next slide. So we're doing, and again, if you've got ultrasound in your clinic, it's nothing, even if they're doing well, get used to what's looking normal in recovery. How much free fluid have you got? And we're tracking to see, is that improving or getting worse? So I often have a look and then I'll re-look a couple of times a shift, a couple of times a day, and just trend it. If you're getting pockets of free abdominal fluid, there's often free gas in there already. That's we've just done surgery. And then I'm looking at my trends. Does the dog looking worse with its perfusion parameters? Is the lactate rising? Do I want to go and get a sample of that to look at my cytology to help me? I'm always a worrier, and I'm worried that he's missed a little bit of the stomach and it's necrosing. And those dogs, if you don't pick that up early enough to get them back to surgery, they die pretty horribly on you. The other thing too, a heme abdomen, I've had a few of those over the years where the small gastrics, initially when they're in surgery, they all seem to be not bleeding, everyone's pretty happy. As they continue to cardiovascularly improve and be, their blood pressure and everything's better, often it's in the post-op period, those little vessels decide to ooze, and we can have quite large heme abdomens there. So just don't, think outside the square of what else can be happening. Next slide. So if you're going to tap the abdomen, and this is something where we'll run a piece, if it looks really bloody, run a PCV-TP on it. If it's got a high PCV, you've got blood loss in there. Are you wanting, what's happening? Sometimes we've had them where we've just given tranexamic acid to help them with that clot stabilisation, plus or minus retransfusing. If it's just a heme abdomen with no breakdown, we'll give them that blood back if they need. It depends how much it is. But generally, if they're dehiscing or got, a gastric, the stomach is perforating, or you've got a high GI ulcer that's perforating from a bit of very unhappy gut, is if you've got signs of intracellular bacteria, then, and always if you have, everyone got DiffQuick, do you do your own in-house staining for blood smears? A handful of people. DiffQuick is something you could teach and look at blood smears and look at cytology. You just need the 3 different stages that you fix your slide in. It's a very cheap and useful way of looking at bloods, looking at patients, assessing them in-house. So we'll do blood smears on our critical patient, and I'll just look at them to save the owner money on repeat haematologies away. So, and you teach yourself. I've taught myself to look at blood smears. So it's something all of you could get more confident at. And then in turn, getting confident at abdominal cytology. The only tip I say is we have dermatologists in our clinic. They like to put their sticky little things all in the pot. So if I'm ever looking for bacteria, these little circles in the intracellular in this neutrophil, I always stain it fresh out of the bottles. I don't do it into pots, since I don't want contamination. This whole comparing glucose and lactate and everything, this when you're looking at your fluid, look, sometimes there's studies that are showing that this isn't reliable, especially in a post opened up abdomen. But I kind of take it with a grain of salt with the rest of my clinical picture. If the dog looks like it's doing really poorly, the free fluid's increasing, the glucose is lower than the body, and the lactate is higher, and there's all these kind of cut-offs they recommend. But I kind of look at a bigger picture. It may help me say, right, I want to send that patient back to surgery. There may not be bacteria, especially if it's a gastric or high GI leak, because it's very acidotic, and sometimes we don't actually have bacteria. But if you've got quite horrible flocculent looking free abdominal fluid and a dog not doing well, I've had times where I've had to push the surgeon a bit, but you'd rather go back in and look than ignore it, because it's a death sentence if you ignore it. So repeat your imaging, keep looking in that abdomen, and revision surgery. If those owners can't go back to surgery, those dogs, humane euthanasia is sometimes indicated. Sometimes we've sent them back to surgery and they're actually non-viable. They're not resectable. So ready to go home. We discharge when they're bright and ambulatory, so they're up and about. They've been transitioned to oral analgesia, so often with ours we've got a fentanyl patch on them and some oral paracetamol at that 10 to 20 milligrams per kilogram per Oz twice a day. And they're eating and drinking, they're not vomiting or regurgitating, and their arrhythmia is kind of managed on their oral sotalol. They generally need sotalol for 2 to 4 weeks, and our cardiology team re-see them to be able to wean them off it. But if you need it, most of the time a GDV, all the underlying inflammation has all settled down by the time we're 2 weeks down the track, and so being able to discontinue your sotalol then. So you're going to resuscitate them, you're going to resect if needed, and watch really closely in that post-op period, and hopefully get these guys home to their owners. And my other comment too, with Chris saying about how they will, if you don't PEXI them, they'll tours. Over the years, I've seen a few tours around the actual PEXI. So the PEXI site has stayed intact, and then we've had a partial torsion. So don't just rule it out that it can't happen again if you PEXI them well, or we've had the PEXI not survive, and not take. Going through clearly with these owners, trying to prevent this happening again. We talk to them about, feeding slowly, having those slow feeder bowls, trying to not one big meal at once, so splitting the food into multiple smaller portions. I still say I don't encourage exercise after eating, and you really try and help them understand how it happened, and if they have another large breed dog, we talk to them about it as well, and have any early signs, really clearly know when to bring them into you. And we will do elective gastropexes, which I might just let Chris comment on those large breed higher risk dogs. If you're in there doing a spay, are you pexing them?
Yeah, great question. It's a discussion with the owner, so it's all about risk and consequence. And so we always have the discussion with those owners that the animal is coming in for surgery, particularly abdominal, and how they would feel about doing an additional procedure to potentially prevent a life-threatening condition. So it's a very individual discussion, I think.
All right, I think we've got a few minutes for questions.
Excuse me. Pre-operative administration of lignocaine to reduce the VPC and VT.
So the lignocaine?
Pre-operative.
Yeah, so there is some studies that have looked at preoperative lignocaine. There's actually a few flaws in how they designed the study. It's not going to do any harm. I don't know if it definitively, if they're very, their arrhythmias are either going to happen or they aren't. Definitely treating them with lignocaine as soon as they happen, or having them on that lower pre-op rate of 20 micrograms per kilo per min, which can, in combination with your lignocaine, with your analgesia, help with your whole pain relief program. Look, we don't routinely, but it definitely can be done. I wouldn't say don't. Yeah.
Excuse me, sir. So I have a question. So coming to the how crucial or critical it becomes to assess a cardiac troponin level in these cases. So do I need to do it before the surgery, and consecutively how frequently do I need to do whether the troponin levels are coming down or not?
Which levels? The
Cardiac troponin levels.
The cardiac
Troponin.
Not before.
Troponin.
propylene. Troponin. Yeah, so no, look, I guess we're not spending time doing that. We know we need to correct that underlying. So we're not doing cardiac troponins or pro-BNPs on them. We're watching for arrhythmias. If we've got marked arrhythmias, we will have our cardiologist echo them. So I guess that's an in-between where we actually can get a really good assessment on their systolic function and any underlying cardiac disease. But generally, if you don't have underlying cardiac,
Really sorry to interrupt, but I request all the guests to please be seated over here only, as we will be felicitating our guests because Professor Christopher is leaving soon. So I request everyone to please be seated, ask your questions, and then we will be starting with the felicitation ceremony. Thank you. You can continue.
Hello. No questions.
so yeah, to answer that, we're not routinely, but if we're worried, we are getting a full cardiac assessment. Whether or not, if you've got it in-house and you're seeing a trend of improvement or deterioration, but ultimately the underlying treatment is to fix the perfusion to that heart and ride out all the reperfusion kind of arrhythmias and everything by having that antiarrhythmic in for a period, and then that heart normally makes a full recovery.
And sometimes post 72 hours after the surgical correction, still we see VPCs. Is it something to be concerned or worried about, or the dog is eating fine, pooping fine, and it came back to its routine? So can we discharge the dog to home?
Yeah, so if you don't have any of that signs of malignancy, which in the next talk I go in a bit more detail, if you've got occasional VPCs or they're continuous but it's not fast, that patient will be cardiovascularly stable and you're okay to get them home even without them 100% normal. If they've got fast rates, so VTAC, R on T, where it's repolarizing and depolarizing almost at the same time, there are times where I definitely want that better managed before I get them home. So their ventricular arrhythmia just needs to be non-malignant, we say, so just nice and slow and calm that we would get them home.
Coming to a question for Sir.
Just a second, once again, please. Also, I have a few very important announcements to make. To please be seated, and please don't go anywhere. Thank you.
भी है, madam. Questions.
Sir, in some cases we can see the stomach, some part of the stomach is not viable or not gets necrose, or the color turns to black or red. So is it advisable to go ahead with a partial gastrectomy and take a risk? So how much of the percent of the stomach do we need to be viable?
Yeah, it's generally a very specific area of the stomach that becomes non-viable. So as long as it doesn't involve the cardia, you can remove 70% of the stomach. You just need a continuous tube to make it all the way through. The only times that I would recommend euthanasia, if it's necrosis around the cardia, then I think these cases are non-salvageable. It's tragic, but the reality is the animal will not survive. But the vast majority, we can resect that out.
Thank you.
Madam.
Oh, yep.
So I have two questions. You just mentioned about pneumothorax. How did that happen? Like, what would be the reason of that?
I can comment on that one. It's generally when people make the incision in the abdominal wall too cranially. So they cut through the diaphragm and they pexy to the diaphragm, not to the transversus abdominis. That's almost always why they get a pneumothorax. The surgeon's made an error. So behind the last rib. Okay. If you're not behind the last rib, you're in the thorax. And then Ellie is very cranky and she sends you back to fix it sometimes. So caudal to the last rib.
So my second question is, in India, mostly GDV occurs because of the foods only. We give all types of foods to our pets. So suction is okay. We do a lot of, sometimes it doesn't come out through the gastric tubes. So is suction a part of...
Yeah, good question. So I will try and reduce the gastric volume as much as possible before I rotate it. So that's either passing a stomach tube if we can and trying to relieve some of that compression. There is sometimes with a lot of food and you can't make it smaller. But you can potentially put a catheter, just like you did a trocar preoperatively. You can do that intraoperatively. I attach it to closed suction so that we don't get contamination. But I try and reduce the stomach size before derotation.
Yeah,
and any intra-locally carminatives or anything, we have done a lot of experiments with putting local sodium bicarbonates or carminatives to prevent the immediate reoccurrence. So is any reference from your end?
Not that I know of any compelling evidence to suggest that. I think, again, the major problem is malpositioning of the stomach. You reposition that and the animal will start to normalise itself.
And just a comment,
All right, thank you so much, everyone. We can continue with our questions later. I have a few very important announcements to make. First of all, thank you, Dr. Ellie, and thank you, Professor Christopher. You can take your seats. And the important